Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. In the previous lectures, we have been discussing about some clinicals of the heart, and during our discussion, we have seen how to put a central venous line through a main vein into the right atrium. And this, during that discussion, we have seen it is the vein that is used, it's not the artery. It's different from the arteriography or angiography, which is done through the vein, which is done through the artery. But here the central venous line is put through a vein, and then we have seen atrial septal defects and basic knowledge of atrial septal defects. We have seen why it occurs and what types are there. The further details are not needed here, and I have selected only those sections which has been given in the standard anatomy book, which is used by UHS, that is the KLM, the Keith L. Moore textbook of anatomy. So today we are going to discuss about the percussion. Here in this diagram, you are seeing, in this photograph, you are seeing that a doctor is percussing the chest of a patient. Here you see that one hand, left hand has been put over the chest, and most probably this finger, this middle finger, is in a intercostal space, say second, and with the help of other finger, tapping has been done over the finger, and the dullness, the sound that the is it solid or fluid or it's gas or air, that has been percussed here to see the dullness of the air, and you will feel it can be felt, and it can be practiced normally, and this is the way how the percussion is done on the patient. And percussion of the heart means is to define the area of the heart over the chest. To define that, the percussion defines the density and size of the heart. So percussion is done in that area of the heart, is create a vibration by tapping the chest with the finger while listening and feeling the difference between the sound waves conduction. Percussion at the third and fourth and fifth intercostal space from the left anterior axial line to the right anterior axial line. Normally percussion note changes from resonant to dullness. So when you percuss from this area to this area, means from the or from the right side, third intercostal space, third, fourth, and fifth, and towards the left side, or from the left side towards the right side, the mid axillary line, anterior axillary line, and mid axillary line, then you can feel the difference in the dullness in the percussion node, and that can be listened, that can be felt. This basically is the difference in the sound wave conductions. And so the area of heart dullness, cardiac dullness, can be felt or listened. Normal percussion note changes from resonance to dullness because of presence of heart, approximately 6 centimeter lateral to the left buttock of the sternum, here 6 centimeter from the bottom of the sternum. So heart can be percussed, but this is not most commonly used nowadays. Stroke or cerebrovascular accident. Why to mention this here before we go to study the valvular heart disease? Because this is a very much complication of valvular heart diseases, especially on the left side of the heart, where the mitral valve is present, and diseases of the left atrium, and diseases of the mitral valve, where the thrombus or clot on the left atrium or the left mitral valve, vegetations can be formed, and those vegetation through the left ventricle and through the main vessel, they can go straight to the brain and can lead to the cerebrovascular accident. So this is why it is mentioned here before we go to the discussion on the valvular defects. So thrombi on the wall of the left atrium can or in the valve can dislodge, detach, and piece of breakup from them pass to the systemic circulation, occluding the peripheral arteries. It can go to the any artery, but because from the ventricle when the aorta, arch of aorta, the common carotid arteries are very much straight, and there are very much great chances that the dislodge clot from the thrombus can move to the brain. Here the clots can be fatty one, fatty plaques, blood clots, or breaks. They break away from and flows to the brain where it blocks an artery. Okay. The thrombus or the clot is formed within the left atrium or over the mitral valve, but it can break down and can move to the brain, so creating a cerebrovascular accident. And this can present with different effects: vision, cognition, motor function, parts controlled by previously controlled but not damaged part of area of the brain. So here, when the stroke is produced, it can present in this way. And whenever you find, it means that whenever you see a patient of cerebrovascular accident, attention should be paid to see the defect in the heart, in the left atrium, or in the mitral valve. The attention should be paid to diagnose the defect on that. Atrial fibrillation can be there. A blood clot may be in the left ventricle, or vegetation may be present over the mitral valve that may have dislodged and go to the brain. So whenever you find a patient of stroke having these symptoms, immediately investigation should be done to rule out the disease in the left atrium, left side of the heart. So cardiac causes of the stroke, cerebral accident, may be atrial fibrillation, rheumatic heart disease, artificial heart valves, dilated cardiomyopathy, Liebman-Sachs endocarditis, infective endocarditis, merantic endocarditis, and left atrial myxoma. Means it's a type of benign, you can say, condition of the left ventricular in which the muscles there is growth in the left ventricle myxoma, growth in the left atrium myxoma. So these are endocarditis means different kind of conditions which in which there is inflammation of the endocardium of the heart, endocarditis. So this can also lead to the severe cerebrovascular accidents. When the valve are damaged and replaced by the artificial valves, they can also, in the rheumatic heart disease, because in the rheumatic heart disease, valves are very commonly affected. In the atrial fibrillation, when the blood clots are present during the atrial fibrillation, that can lead to the cerebrovascular accidents. So these are the cardiac causes which should be ruled out when you see a patient with the cerebrovascular accident. So first of all, we are going to see valvular heart disease. Only brief mention of the valvular heart disease will be given here as given in the KLM, and details are not needed here to be given because more clinical you will see later on when you will go. Here is the basic valves of the valve. Here is the tricuspid valve between the right atrium and the right ventricle, mitral valve, bicuspid valve between the left atrium and the left ventricle, then in the pulmonary valve, then is the aortic valve. The here are the cusps, nodules, and luminary of the cusps. Here are the valves of the leaflets of the valves of the mitral and tricuspid valve. We have discussed these earlier. So types of valvular disease there may be narrowing of the valve, producing stenosis, that the blood flow from the one side of the heart to the other side will be slowed down, and this is because of narrowing of the orifice, stenosis. Regurgitation means the backflow of the blood. When the ventricle they contract, the blood is pushed back into the atrium due to the defect in the valve, basically tricuspid and the mitral valve, but other valves there. So regurgitation means valve do not close all the way, so blood leaks backward into the proximal chamber. That may be left atrium, that may be uh, right atrium, or that may be according to the valve. So stenosis and regurgitation, two types are seen. So first we see valvular stenosis is there is narrowing of the valve. Leaflet may become fused or thickened, so they cannot open freely, obstruct the normal flow of the blood. There will be effect that the chamber behind the sphenoid valve will be under great stress and that will dilate. So they must generate the pressure or work hard to force the blood through the narrowing opening. So initially the compulsion from the additional workload, gradually hypertrophy and dilatation of the myocardium will occur, and that will lead to heart failure. So this is the stenosis. The back chamber is affected because it has to say, for example, if there is aortic stenosis, then the left ventricle has to put more pressure to push the blood from the aortic valve into the peripheral circulation, and with the time the workload over the left ventricle will increase due to the stenosis in the aortic valve, and with the time the left heart will dilate and the myocardium will be damaged. The heart will hypertrophy, left side will be hypertrophy one, and at a certain point it will lead to the failure of the left ventricle. This is an example in the valvular stenosis. So when there is regurgitation, there is scarring or retraction of the valve leaflets, weakening of the supporting structures, the chordae tendineae, the papillary muscles, they can be weakened. The chordae tendineae may be damaged, which are holding the valve, and that then it will lead to the leakage of the backflow of the blood. Say, if there is damage to the tricuspid valve, there is damage to the chordae tendineae or papillary muscles of the right ventricle, and there is damage to the chordae tendineae of the tricuspid valve. When the right ventricle will contract to push the blood into the pulmonary system, through the pulmonary valve, the blood will flow back through the tricuspid valve due to the damage to the valve into the right atrium, and then the right atrium will enlarge. So there is leakage or backflow of blood from one chamber to the proximal chamber. The cause is to pump some blood twice as blood comes back into that chamber. So right atrium is not fully, it will not be fully emptied with every beat. It will dilate to accommodate more blood. So the usual blood it needs to pump regurgitated blood. The blood which has come back into the right atrium from the right ventricle, it needed to be pumped again. So there will be dilatation, hypertrophy of the right atrium. Ventricular dilatation, hypertrophy eventually leads to this heart failure again. So if there is, say, there is regurgitation of the aortic valve, say for example, then the blood will come back during the ventricular diastole from the aorta into the right ventricle. So now if the again this blood has been pushed again by the ventricle into the aorta, and with the passage time it will accumulate into the left ventricle, and with the passage of time the left ventricle will hypertrophy and there will be failure also due to the aortic regurgitation. Or another example can be taken from the mitral regurgitation. So causes, principles of the stenosis, main causes are congenital, rheumatic and senile degeneration in the stenosis. In the regurgitation, that may be congenital, that may be rheumatic, infective, that may be traumatic, or that may be after myocardial infarction, in which the damage to the cardi tendini and the papillary muscles, and senile degeneration. Senile means with the passage of time, senile degeneration without any cause. So clinical significance of the valvular dysfunction that ranges widely from the slight and physiological insignificant to severe and rapidly fatal effects. It depends upon the degree, duration and etiology of the damage to the heart, and also secondary changes in the heart, blood vessels, other organs. And valvular disorder may be congenital, acquired. Insufficiency may result from pathology of the valve itself or its supporting structures, annulus, tendinous cords, dilatation of the chamber wall. These are the additional factors which can lead to the pathology, which can lead to the incompetency of the valve, that may be related to the valve itself or with the supporting structures. It can be a very acute one suddenly, that a cord ruptures suddenly, so that will appear the regurgitation will be all of a sudden, or it may be chronic with the passage of time, long time. There is scarring, infection, scarring. Then after a time, the main symptom of the regurgitation they appear. That may be sudden onset, acutely. That will be damage to the cords or papillary muscles from myocardial infarction, or it may be over a long time when there is infection, scarring of the heart muscles or the valve, retraction of the valve. So what we have learned, that the first of all, that this disorder, valvular disorder, may be a minor one, insignificant, physiologically insignificant, or it may be severe one, which may be fatal one. It depends upon the changes in the heart and blood vessels and the other organs. Insufficiency itself may be in the valve or in the supporting structures in the heart muscles, cardi tendini and papillary muscles. It can be acute one, it can be chronic one. Acute one suddenly due to the damage to the heart muscles and cardi tendini, and it may be chronic one. And here are shown some valvular prosthesis, here one, because this is a mechanical type. So if a valve are damaged, they can be repaired or they can be replaced by these valves. These are the prosthetic valves. Nowadays, the xenograft means the valve from the other species can be transplanted into the human beings also. So these are the valvular prostheses which are commonly used. So first of all is the mitral valve insufficiency or mitral valve prolapse. Here you see in this diagram, this is the Normal mitral valve, here are the chordiotympani and papillary muscles attached to the valve leaflets. But in this diagram, you see here the chordiotympani or pulmonary muscles may be damaged, and here the valve is protruding into the left atrium. Due to the pressure in the left ventricle, the heart valve is prolapsing into the left atrium, and with that passage of time it may become insufficient, so the blood wave from the left atrium may regurgitate back into the left atrium. So a prolapsed mitral valve, insufficient or incompetent valves with one or both leaflets enlarged, floppy, redundant, and they are extending back into the left atrium. As a result, blood will go back into the left atrium from the left ventricle, and it will produce a murmur, a sound, a change in sound of the heart. Obviously, this will be during the systole. When the ventricle contracts, the blood will flow back into the left atrium, and during systole, it will produce a sound murmur. It is very common, 1 in 20%, and most often in young females it is common, mitral valve. And keeping in this age group, the rheumatic cause or endocarditis cause is very much expected to occur in these females. It may be an incidental finding in the physical examination, but it is of clinical importance in small fraction with the patient suffering from the chest pain or fatigue. So in most of the patient it is symptomless. Only the murmur is present when you listen to the heart, but otherwise the patient is normal. And in those patients who develop chest pain or fatigue, in those patients it is important to treat the mitral valve regurgitation. Then is the pulmonary stenosis. Here you see the pulmonary valve. Here is the normal pulmonary valve, but here you see the orifices. The tenule here are fused together due to some disease process, and then here is only small area is left for the blood to be pushed through. So pulmonary stenosis here is narrowing of the orifice of the pulmonary valve. So the valve cusps, they are fused. Here you can see they are fused, forming a dome with a narrowing central opening. It can be at the infundibular region, where the pulmonary artery is originating from the right ventricle, due to the conus arteriosus, which is underdeveloped, and it can be occur in the valve also. So there are two types, infundibular and valvular. Both type of stenosis produce restriction of the right ventricular outflow, and this will obviously cause the hypertrophy of the right ventricle. So pulmonary stenosis presents with the fatigue, dyspnea, poor weight gain, failure to thrive in infants, hepatomegaly, ascites edema. This is because of the back pressure from the right atrium, the right ventricle to the right atrium, and then back to the systemic veins, back increase in back pressure that leads to these symptoms. Due to the increase in back pressure from the right ventricle, because right ventricle is unable to push the blood through the pulmonary stenosis into the pulmonary circulation. So there will be a ejection systolic murmur, ejection, when the blood has to pass through a narrow passage during the right ventricular contraction, that will produce ejection murmur that will be heard more on the it will be radiating towards the left shoulder. It is the direction of the pulmonary valve. Okay, and this murmur will be preceded by ejection click. So it can be diagnosed in this way. There are other symptoms, but these are enough to know that these will be the sign and symptoms. What kind of murmur will be produced by the pulmonary stenosis? Pulmonary valve incompetence. Now here the valve is not stenosed but incompetent. So when there will be diastole of the right ventricle, the blood will tend to come back from the pulmonary artery into the right ventricle during diastole. So again there will be increased pressure over the right ventricle and that will hypertrophy. So if the free margin, that is the leonules of the cusps of the seminal valve thick become inflexible, that they do not close during diastole, they are damaged, and that will not close completely during the diastole of the right ventricle. So incompetent pulmonary valve result in back rush of the blood under high pressure into the right ventricle during diastole. Pulmonary regurgitation may be heard through the stethoscope. A heart murmur will be heard, and this murmur will be heard during the diastole of the heart, diastole of the right ventricle. Next is the aortic stenosis. The problem is in the aortic valve. The cusps, blood is unable to flow freely from the right ventricle to the aorta during aortic stenosis. Here is the lumen of the aortic valve is narrowed. So what happens here, that this is most frequent abnormality. Born with for those born in early and mid 20th century, rheumatic fever was a common cause. Accounts for less than 10% of cases of aortic stenosis, and the majority of the aortic stenosis is a result of degenerative calcification and come to clinical attention in the 6th decade of life or later. Extra work for the heart resulting left ventricular hypertrophy. So here you can see that through this, the small amount is pushed into the aorta, reduced cardiac output because of stenosis of the heart, and this will be secondary effect the left ventricle. There will be left ventricular hypertrophy. Increase in afterload, but it's aortic stenosis. This comes to clinical attention in the 6th decade after the 60 years of the age or 50 years of the age. Here in this diagram you see narrowing of the aortic valve, and this was previously most commonly due to the rheumatic heart diseases. So there will be a systolic murmur, okay, subvalvular stenosis, subvalvular aortic stenosis, these are the causes. So congenital bicuspid valve, aortic stenosis, rheumatic, middle-aged, and there will be ejection systolic murmur, slow rising carotid pulses because of narrowing of the aortic valve. Blood is pushed through the aortic valve slowly from the left ventricle, and there will be slow rising carotid pulse you can feel. Thrusting apex beat, because the left ventricle, the pressure overload in the left ventricle, the apex beat can be felt and it is thrusting. Narrow pulse pressure means difference between the aortic and diastolic pulse pressure is very much less, and there will be pulmonary congestion because of back pressure shifted to the left atrium and from the left atrium to the pulmonary veins and then to the lungs, pulmonary veins in the lungs. So there will be signs of pulmonary venous congestion also. Aortic insufficiency from aortic regurgitation. The causes will be the same as we have seen in the pulmonary regurgitation. Backrush of the blood into the left ventricle, producing a hard murmur that will be diastolic in nature. During ventricular dilatation, the blood is pushed back into the left ventricle and it will produce a characteristic murmur. Here you can see backflow of the blood during the ventricular diastole. The blood is coming from the left atrium and also from the aorta back into the left ventricle. So it will produce a characteristic diastolic murmur. So pulse here will be large volume collapsing pulse. That means first you feel that pulse is large volume and suddenly it goes off. That means collapsing pulse. Because the blood comes with greater amount from the left ventricle, but due to the backflow of the blood from the aorta into the left ventricle, suddenly the pulse disappears, collapsing pulse. Low diastolic or increased pulse pressure. Bounding peripheral pulses, bounding because of more blood is pushed with every beat. Because the blood accumulates more after regurgitation into the ventricle, so will be bouncing peripheral pulses. Femoral root may be heard, pistol shot, that the blood will go through the femoral artery like a sound of pistol. It will be sound like this. Murmur will be early diastolic murmur because of the backflow of the blood from the aortic valve into the left ventricle. Systolic murmur because of greater amount of the blood going into the aorta, increased stroke volume, then you may hear a systolic murmur. And also a soft mid-diastolic murmur, Austin Flint murmur, can also be heard over the aortic valve. Now, to diagnose these valvular heart diseases, the most commonly used investigation is echocardiography. Here we see an echocardiogram photograph in which it's just like the ultrasonography, but in this the probe is different, and only the heart valves, heart functions, heart chambers, they are seen. Left atrium, right ventricle, and left atrium. Here the valves are seen, connecting the two things, and then the function of the heart can be assessed by this. Echocardiography is ultrasonic cardiography method of graphically recorded position and motion of the heart by echo obtained from beams of ultrasound waves, similar like the ultrasound waves used for investigation of the abdominal or other things. Techniques may be detected as little as 20 milliliter of fluid in the pericardial cavity, such that the resulting from the pericardial effusion. Doppler echocardiography technique is that demonstrate and record the flow of the blood through the heart and great vessels by Doppler ultrasonography, making it especially useful in the diagnosis and analysis of the problem with the blood flow through the heart, such as septal defects, valvular defects, and especially on the left side of the heart. So through the echocardiography, we can detect the defects in the septal defects. We can detect the valvular problems in the heart, stenotic or regurgitation, using Doppler ultrasonography, color ultrasonography. Here we see the Doppler echocardiography. Here is the main pulmonary artery, here is the PDA connecting the artery and the aorta, left atrium and ductus arteriosus. Here is the Doppler ultrasound showing the echocardiogram. So we have seen echocardiography. Only to know about echocardiography, it's ultrasonic cardiography, just like the ultrasound, and it is beneficial in detecting the pericardial effusions as little as 20 milliliter of the blood fluid in the pericardium. Also, it is most useful to diagnose the valvular heart disease and septal defects. Stenosis or regurgitation can be detected through the echocardiography. So in this lecture we have seen most common the valvular problems and the associated problem. Inshallah, in the next lecture we will discuss about the other clinicals of the heart.